Some would say that this person meets this here, but it's not impacting their everyday life because all they do is sit down. They don't have dementia. Or let's say you're 60 years old and you're in management and you have some mild memory concerns or mild memory loss. It would take very little deficits in cognition to start to impact your everyday life if you're in a very high-pressured, highly achieving type of occupation. So this part here is very subjective, but we have to be able to tie in the two. We have to say there's deficits in functioning, that's objective, and then we have to look at the patient's life and kind of decide where the bar is at and move it accordingly. Alzheimer's makes up 50 to 70% of all dementia cases. So Alzheimer's is a type of dementia. That's important. That's oftentimes misunderstood. You'll say, well, do I have Alzheimer's or dementia? No, Alzheimer's is a type of dementia, and it makes up 50 to 70% of the cases. So if you go to your primary doctor and with a loved one with memory loss, they can flip a coin and they'll be right half the time that it's Alzheimer's, and other half, without any testing at all, the other half the time it's going to be something else. Each different dementia has a differing prognosis and course because it is a different pathological process that is occurring that causes the dementia. And it's through that prognosis and course that we can direct treatments based on the type of dementia it is that we're dealing with. Again, especially the earlier we are able to identify that dementia. So after age 65, it's a greater than 13% chance with a 2% increase per year of life. So age is a major risk factor. Not one we can really do much about, but it is still a risk factor. Well, you can do something about age as a risk factor, but the alternative is not very good. After age 85, greater than 50% chance that you will be diagnosed with a dementia. Right? This is a pretty shocking statistic, right? But when I work with patients, and especially in their octogenarians in this age group, and I diagnose them with mild dementia, I tell them, I'm actually not that worried about you, and it's not because I don't care about you. The older you are, before your brain reaches the point of a dementia process, the much slower the decline will be, especially if we can implement medication treatments to even slow down that decline even further. So it's a much different story when there's a diagnosis made at 65 rather than 85. And if we manage this properly at age 85, excuse me, there are things that can be done that really will not have that significant of an impact on the person's overall quality of life. Sure, there's some changes that may need to be made down the road, such as with driving or fully independent living, etc. But if we catch it early enough and start treatments early enough, we can really do a lot to try to sustain brain function for as long as possible. And I ask these patients, I say, are you worried about what's going to happen 10 to 15 years from now? And generally they kind of laugh at me and say, no, I'm not too worried about that. At age 60 or 65, yes, we have to start worrying about that. So risk factors, well, age, genes, vascular health, huge risk factor into the development of a neurodegenerative type of process, a dementia type of process. Well, so why is that? Well, our brain utilizes 20% of the oxygen and nutrients that are supplied by our blood, okay? But it's only 1/50th of the size. So it's a very greedy user of our blood supply. So you can imagine that anything that affects our vascular health, diabetes, high cholesterol, hypertension, hardening of the arteries, is going to affect our brain health. And those that have diabetes, hypertension, high cholesterol, are at a greater risk towards developing, well, vascular dementia, number one, but also Alzheimer's dementia as well. Education. is a risk factor. Kind of an interesting notion that the more education you have, the less risk you have of developing dementia. Well, why is that? Well, there's a couple of reasons. One is that higher education is correlated with, there's certainly exceptions to the rule, but is correlated with more white-collar type of work. Lower education is sometimes correlated with more blue-collar type of work, where you can be exposed to risk of injury, toxins, and other types of environmental exposures. Think of people working down the docks or in construction or other types of work. And those can play a role in a later life brain susceptibility. One theory. Another theory is that with greater education, there's generally a reason why someone goes to school, because they like learning. Well, that doesn't just stop when you're at 21 or 24 or whenever you finish up your education. It generally means that you continue to enjoy learning throughout your life. So lifelong learning, a lifelong desire to seek knowledge, is correlated with a healthier brain, because you are doing things throughout the lifespan that are going to exercise your brain, stimulate your brain, which is known to make for a more resilient brain and a healthier brain. Lifestyle is certainly a risk factor. And again, diet relates to your vascular health, obviously, very closely. Your level of activity and exercise relates to your vascular health, exposure to toxins, etc. And then previous history of head injuries. Now, this isn't just one or two isolated head injuries that a lot of us has probably had in our lives. That's not correlated with later dementia. It's repetitive brain trauma that is, such as those found with boxers or NFL players. NFL players retired are 19 times more likely to develop early onset dementia than the rest of the population. And the theory is because of the repetitive brain trauma that they experience. So when we think about dementia, we'll oftentimes think about a continuum. So here we have what's called a latency period. A latency period is when you have some sort of pathological process that's occurring in your body, yet there is no expression of symptoms. Okay? So with Alzheimer's dementia, AD, the latency period is thought to be between 10, 20, even up to 30 years long in some research. That there is a pathological process occurring, meaning that the plaques and proteins are developing in the brain, but yet there is no expression of symptoms. As you go through time, so this arrow is time, as you go through time, then you'll start to have an expression of symptoms. For Alzheimer's dementia, this very early preclinical stage of Alzheimer's is what's called mild cognitive impairment, where they found that a great percentage of these patients will convert to Alzheimer's dementia. And it's just as the symptoms start to manifest, then they start to show memory loss, some cognitive difficulties. Right now, the best we can do is catching it right here, okay? And that's done with lab work, brain scans, neuropsychological testing. That's about the best way that we can do is to capture mild cognitive impairment and diagnosis. And if we capture the diagnosis right here, then we can really extend this arrow much further before the Alzheimer's dementia diagnosis takes hold. So even in the very earliest preclinical stages, we want to start that treatment. And the same thing holds true here for vascular dementia, vascular cognitive decline, is if we can catch the vascular cognitive decline here, we can even reverse it back to the latency period, because guess what? What's causing the vascular challenges in the brain? The hypertension, the high cholesterol, overweight, sedentary lifestyle. If we can do some lifestyle interventions and reverse some of those bad habits, get rid of some of those bad habits, the brain can actually start to work to improve